without any break, we'll get on to the next session. Um, our next session is also interesting. Please stay back. Our next session is also interesting. Um, this is a session on understanding choroidal neovascularization. So we all know that choroidal neovascularization is one of the commonest things that we see in our practice. So we are all overawed by all the various trials, and sometimes it's so confusing that we really don't know what to how to practice managing these patients. So the aim of this course is to kind of simplify things, to give all of you in a nutshell how to manage choroidal neovascularization more effectively. So I'm very fortunate to have an excellent panel with me. We have the convener for this session will be Dr. Ajay Arora. I don't know whether he's and Dr. Thomas Cherian will be the moderator of this session. My co-chairperson is Dr. Rahul Menon. And we have two guest speakers for this session. We have Dr. Parveen Sen and Dr. Prashant Bhavankule. Both of them need no special introduction. So let's start off with the first talk. I would like to invite Dr. Parveen Sen to talk on how multimodal imaging enhances our understanding and management of AMD. Now this is the era of multimodal imaging. All of us have, it's a very fanciful term. All of us are very fond of using multimodal imaging. Is it really essential in our practice, and how much value it adds to our practice is what Dr. Parveen is going to speak to us.
A very good morning to everyone. So I thank Dr. Manoj and KSOS for giving me this opportunity to be in this beautiful town of Calicut. So I'll be talking to you about the multimodal imaging in age-related macular degeneration. So I quote Dr. Spade here. There's a universe of potential signs and symptoms are recognized over the years, and some pattern forming happens and it gets linked together into a constellation of disease. And AMD is one such constellation which has been more recently diagnosed, and imaging has added many more stars to this constellation so that new shape and signs are being recognized. As we know it, AMD initially, as per the AREDS criteria, was about the soft drusen, the size of drusen, then intermediate AMD and late AMD. But now we know that it's not just soft and hard drusen. There are many more. There can be more than 38 different types of drusen that can be seen in patients with AMD. The most spectacular is the subretinal drusenoid deposits, and these are not just simply deposits. They have their own story to tell, which Dr. Rahul is going to let us know about. And these subretinal drusenoid deposits have changed the way we think about drusen, because they are not under the RPE, but they are above it. And you could have cuticular and subretinal drusen existing in the same eye, and then questioning our very origin of neovascularization is this RAP lesion, which we now know originates in the retina and not in the choroid. And you can see that this has not yet established any choroidal connection, and it is only into the retina that it starts. And this has brought about, in fact, retinochoroidal anastomosis may not happen till the very last stage of the disease, though ICG was considered to be the most important diagnostic investigation for this. Now we can easily recognize with a non-invasive OCT and OCTA because the features have been very well described and discussed. So this is how our model of AMD, a simple straightforward model, was based on AREDS, that there's a soft drusen, then focal hyperpigmentation happens, which may either develop into choroidal neovascularization or geographic atrophy. And this is how it has changed. We know that soft drusen may be of various kinds. Focal hyperpigmentation may not happen in every case. Choroidal neovascularization may not be choroidal, and geographic atrophy may not be just an isolation and may be associated with neovascularization. So a more pathogenic based classification has been proposed where they say that soft drusen can develop either into geographic atrophy if it regresses or it progresses, it forms macular neovascularization. Pachydrusen has been added to the spectrum, and this has resulted in a newer classification system, which is the new Conan classification system, where the term choroidal neovascularization has been moved over and shifted and replaced by macular neovascularization, because we know that type 3 CN is not a CNVM at all. So this is what has triggered, the new imaging technology has triggered a change in the classification system altogether. Also, it has improved the hypothesis, our understanding of the disease. We know that there are these choroidal watershed zones which are present because macula is supplied by the choroidal arteries, and these are nothing but end arteries leading to a hypoxic area at the posterior pole. And we know that now that this hypoxic area is the one which is the cause of VEGF production, which results in neovascularization. And with the new imaging technologies, we can actually pick up these choriocapillary flow voids in the choriocapillary space, and we know that they increase with age. They are seen more in patients with AMD, more in patients with geographic atrophy, and much more in patients with MNV. And in the patients with MNV also, the immediate area surrounding the MNV will have higher choroidal flow deficits. The origin of the MNVs is now hypothesized to be from the rod cells actually, because in patients with SDD, they are known to have dark adaptation difficulties and they are known to have rod dysfunction. So not only we know the cause, we are also beginning to understand the role of various cells in age-related macular degeneration. Not to leave geographic atrophy behind, we have new classification system. We know that it can be very well seen on FAF, but OCT has been the game changer, where we know that you can even see it before autofluorescence shows up. We have the C-RORA, we have the I-RORA, and the newer classification altogether on geographic atrophy as well, which gives us a lot of prognostic implications in describing these areas of geographic atrophy. And we know that it is the type 3 which can cause more geographic atrophy as compared to the other two. And we also know that which kind of drusen can cause more geographic atrophy. So we can prognosticate these lesions. We can talk to the patients and tell them, reassure them if they don't have any of these risk factors for progression of geographic atrophy. Polypoidal choroidal vasculopathy has also been, the classification has been changed. It is now moving more towards a non-invasive kind of imaging techniques which have described how to recognize this on OCT, and ICG is no longer the gold standard. Not only for diagnosing, but for seeing the recurrences and for guiding you the treatment as well. We need not depend on the ICG at all. So there's a definite shift to non-invasive imaging techniques. What about enhanced imaging techniques? Have they changed? They have changed the way we look at DME, but have they changed the way we look at AMD? Yes. So we have seen that the wide angle viewing system has shown us that the venous congestion may be the root cause for the dilated choroidal vessels which are seen in PCV. And this, you can see a loss of anastomosis at the posterior pole in patients with PCV. In fact, anastomosis between superior and inferior vortex vein is seen in almost 90% of the cases with PCV. And if this anastomosis is seen around the horizontal meridian, the patients may develop PCV and CSC, and if along the vertical meridian, they may develop a peripapillary pachychoroid. So it has improved why our patients have a different spectrum of disease. But what about AMD? Does venous congestion have to do much in AMD? Well, it is not yet mentioned in literature, but these are a few of my cases and some experience that I had. You can see this is a patient of geographic atrophy, but here again, the anastomoses are visible. This again is geographic atrophy, and by no means would you call these vessels, large choroidal vessels crossing the macula to be normal. Does it help us in decision making, which is the second part? First of all, yes, to diagnose AMD, differentiate it from masquerade syndromes like vitelliform disease, and not to forget that you may have vitelliform disease in AMD itself. And these are some acquired vitelliform lesions which may be present in AMD patients. It helps us determine the disease activity at baseline, and we know that fluid is the most important marker of the disease. It is giving us the OCT biomarkers to tell when to start treatment. Though we know fluid is the most common disease marker, active disease marker, not all fluid needs treatment. Imaging techniques have shown us that drusenoid PEDs may have small pockets of fluid, and it has also shown us, Octa has shown us that you may have membranes without fluid. Fluid without membrane and membrane without fluid, both are the conditions where you would like to watch and not to treat, because membranes without fluid may actually be protective and nourishing the RPE, and you treat them, it could increase the rate of geographic atrophy. Imaging classifies the disease for us. We can classify and see very well a sub-RPE type 1, type 2, a mixed variety, or a type 3 lesion, which can be very well seen, and the response of each of these membranes to treatment would be different, and imaging is telling us how to define the response. This can be a functional or a morphological response, which is based upon OCT. Assessing the response. Here is where the OCT biomarkers come in place. We have these lists of biomarkers for AMD as well as for PCV, which tell you whether this patient is going to do well with this anti-VEGF or would need something more. When is it safe to stop treatment for our patients? The present understanding till now is we don't know, maybe till death do us part. But yes, some exit strategies have been established, but in spite of this, the results are poor. Almost 41% of these eyes may have a recurrence by the first year, and as much as 79% by 5 years. So we still do not know where to exit until unless we have something called a futile lesion, which again imaging tells us what is a futile lesion. So if you have something like this on the left-hand side, large degenerative cysts, which are not responding to a trial of anti-VEGF, it will be futile to treat them, and you are safe to suspend the treatment until unless patient reports you of a drop in vision. So yes, imaging and AMD is like your best friend. It's hand-holding you throughout the journey. I think they have the slogan, Zindagi ke saath bhi, Zindagi ke baad bhi. So it's almost like forever there with you. It has led on to formation of artificial intelligence algorithms, and believe me, AI can see in imaging what you and I cannot see. So it may actually throw you out of your business. But then we must remember, imaging is just like fire. It is useful servant, but a dangerous master. And bottom line, it is not a substitute for clinical correlation. Thank you so much.
Thank you, ma'am. It's excellent talk. So next, I would call upon Dr. Prashant Bawankule. He will be talking to us about vitreous hemorrhage in PCV.
While Dr. Prashant, starts his talk, I think Dr. Praveen has raised a lot of important things with neoclassification. It makes us understand AMD much, much better. We are able to not only, categorize our lesions, but also eventually follow them and treat them well. Do we have time for the question for Dr. Later on?
as Dr. Prashant is getting ready, I think we can ask if we can ask a few questions. Dr. Parveen, Madam, I was just thinking, I mean, do we need to do multimodal imaging in every situation? I mean, there are some straightforward CNVMs where you just do an OCT, and where nowadays with anti-VEGF coming in and everybody trying to, inject, and many of the people are just injecting based on OCT characteristics. So do you think that that is a good practice?
So I definitely feel that once you start treatment at the baseline, you should have more than a single investigation which helps you. You may not always go in for an invasive one, but OCT and OCTA, if you have, can give you a good impression. But when you are following up, you can remove out a lot of FFA, ICG, which are not necessary to be repeated every time. Another indication is if you are in doubt and your AMD lesions are not responding to first, second, third injection, then you would definitely want to know what is going wrong, and this is the time when you would go in for an FFA ICG as well.
Okay, I'm ready. Shall I?
Please go ahead.
Thank you. Thank you, KSOs, for this wonderful opportunity. Yes, friends, today I would be speaking on vitreous hemorrhage in PCV lesions. Well, these are very fragile lesions which we are all aware, and the incidence of subretinal bleed is as close to 30 to 64%, while vitreous hemorrhage is as high as 4.5 to almost 20%. So this is a video bouquet of few of the cases of ours on a long follow-up, how we treated it in the case of vitreous hemorrhage. Well, this is a 46 years, 50 years female who presented with this fundus initially. So a tubular vesicle-like lesion was the presentation, and this is on a high MAGI, which you can see. And this is the OCT which shows double hump sign. Angio was shown, which was not much contributory. ICG again was not very contributory at that point of time. And so at that point we decided to just watch it because there was no fluid, as Dr. Parveen has said, there was no fluid. So we had to watch this particular lesion. But exactly 3 weeks later, she presents to us with a sudden diminution of vision of 3 days duration, and her vision had dropped down directly to 2/60 from 6 parts. And this was the massive subretinal heme which she had at the presentation exactly 3 weeks. And this is double hump sign. At this point, we want to give her an option of a aflibercept, but the patient couldn't afford it. And so she went with a biosimilar at this point, and first biosimilar was given. And this is 8 days later, she had a total dispersed vitreous hemorrhage. A B scan was done, and which showed that there was a small lesion naturally corresponding with the macular lesion. And that time we decided to continue because we had just injected 7 days ahead a biosimilar, a conservative management for this patient. Now this is 6 weeks after that. She had been meanwhile to a higher center for a second opinion. They also advised her to continue with anti-VEGF treatment. And further hemorrhage kept on increasing. This is again, you see the lesion on a B scan with a vitreous opacities on a lower gain. And this is 1 month after second anti-VEGF. We continued injecting her with simple anti-VEGFs, hoping that the amount of a bleed would come down. And this is what happened finally after second anti-VEGF. The hemorrhage increased further. The lesion size we thought was on an increase, so we decided to go ahead with vitrectomy with anti-VEGF. Here the vitrectomy as such is not much difficult, except that the vitreous PVD is not existent and it is quite sticky. And you can see a small, a large after clearing of the vitreous hemorrhage, you can see the exudates, hard exudate as well as, which then we ended up giving one more anti-VEGF at that point. So just clearing the vitreous hemorrhage here is not sufficient. We continued injecting the anti-VEGF following vitrectomy for vitreous hemorrhage for a PCV case. And these are the post-op cases, pictures, subsequent pictures of the same patient where the vision then improved. Most important message in such cases is the surgery does not end the disease. In fact, you have to continue treating the root cause of the vitreous hemorrhage, and this is what happened. And this is a subsequent follow-up for you, how it improved well. And this is 1 year later where you can see she also underwent cataract surgery, and this is the picture at the end of almost 2 years. So this is just in short the timeline how the hemorrhage, a PCV lesion behaved. Well, now we move on to the case number 2. She's a 70 years old female who presented with 6/9 vision, and this was the fundus at picture presentation. You can see large serous PD-like lesions, and This was the OCT at presentation, and this is the fundus fluorescein angiography. You can see pooling as well as the leak over there. She received 3 dosages of aflibercept at 4 weeks interval, and this is post 3 injections of aflibercept. We thought that we have conquered the disease and the vision had restored back to 6/9 with a flattening corresponding on an OCT. Well, but what we see is 7 weeks later, it comes back with a vengeance, and this is the lesion when we saw about 7 weeks after we had 3 injections of aflibercept. Being a VIP, high-profile patient, she again underwent a fluorescein angiography, ICG angiography. We thought we are seeing some lesion there, polyplaque lesion, so we treated her with photodynamic therapy as well as aflibercept. And this is post-PDT and aflibercept follow-up. As you can see, multiple injections were given. Somehow, the PED was not budging. It would come back again after 2 to 3 weeks. And then 6 weeks later, in spite of 4 injection means total 7 aflibercept, she presented with floaters, and this was the hemorrhage. There was a central core vitreous hemorrhage at this point of time. And you can see the OCT which we could acquire with a SLO-based technique. We could see the lesions to be there. We went ahead at this point of time, again continuing with the aflibercept molecule. And this is 1 month later, again further aflibercepts were given. But 3 months later, this is the lesion, and you can see how it responds. So this is how sometimes it keeps just a simple hemorrhage where a simple observation can help you by continuing along with it an anti-VEGF molecule, preferably in such cases a aflibercept, or nowadays we have a brolucizumab to treat with. So this is just a timeline for you how the lesion behaves in such cases, and you don't need a vitrectomy for such a small vitreous hemorrhage. Now case number 3 is a 85 years old female, and you can see the B scan. She came to us with vitreous opacities, vitreous hemorrhage. We saw a high dome-shaped mass at the posterior pole, high surface reflectivity, mild to moderate internal reflectivity. And we knew the patient had a previous case papers which said that they were treating a case of a PCV, and so here we directly went ahead with vitrectomy because the amount of vitreous hemorrhage told that it will unlikely to absorb spontaneously. And you can see a chicken fat vitreous hemorrhage. Again, as you can see, a vitreous hemorrhage being cleared, and then the PVD was induced. You should try to induce the PVD, but it is very sticky in such cases. And you can see a large subretinal heme mount across the whole posterior pole, almost extending up to the equator. Now, if you see, the fovea is also involved. Here, we decided not to do retinotomy and put any TPA. We just ended up just putting an aflibercept injection, and then post-operative positioning was done, and 2 more injections of anti-VEGF were continued. And this is 1 year later, 2 years later. Again, she presented with a further vitreous hemorrhage in the same eye. And this time again we did a vitrectomy with ILM peeling at that point was done in this particular patient, and this is subsequent follow-ups of the patient after second vitrectomy in the same eye. So now next case, this is 72 years with, she was diagnosed elsewhere as a peripheral exudative PCV, and this is the picture at presentation to us. We directly went ahead with pars plana vitrectomy. As you can see, we are doing a vitrectomy. Again, as I said, vitrectomy is not very demanding. We'll just come to the post-operative follow-up, that is important. And exactly a month later, we had 636 recovery. She further received 3 more dosages of injection bevacizumab at 1 month interval, and at 4 months, she was 636. So this is what 2 years later the picture is. Again, there was a bleed in the same eye, and this is reactivation of PCV with the vitreous hemorrhage. At that point, we simply did a fluid gas exchange, OPD fluid gas exchange along with a anti-VEGF. And we also, after later, we did a triple freeze cryopexy for the peripheral lesions. And this is what we see again. This is in fact the case sheet of it, the front page diagnosis sheet of it. You can see the number of injections, the number of procedures this patient received. So PCV sometimes is unrelenting, and you have to chase the disease, and you have to do multiple procedures. So this is the last case in this series. She has already received 7 anti-VEGFs elsewhere, and she comes to us with a sudden decreased vision. This is the OCT at that point of time, and we did an FFA, which you can see the multiple lesions over there. She received 3 injections of anti-VEGF, and this is post 3 injections of anti-VEGF. She had 636, but 6 months later, She comes back to us with a decreased vision. She again had a vitreous hemorrhage, a choroidal mass-like lesion, but we were sure it was a case of a PCV. B-scan was done. Again, it showed massive, almost kissing choroidal-like lesions. Okay, it was such a massive lesions at presentation. We decided to observe at that point of time, and 2 weeks later, fortunately, those mounts subsided, and that is the time when we thought we should follow it up further. But 5 weeks later, the hemorrhage kept on increasing, and at that point, after the mounts had decreased, we went ahead with vitrectomy with anti-VEGF injection. Here, the vitreous hemorrhage was quite massive, even there was a spillover into the antechamber, and so the view here is quite pathetic. You cannot see, but yes, you have to be persistent, you have to be careful. A wide-angle viewing systems definitely help you in such difficult situations, and you can see a massive mount over the posterior pole, just sparing the fovea. So this is the post-op follow-up of this particular patient. So friends, PCV has a fragile lesions which tend to be not necessarily intraretinally or subretinally, but also sometimes a breakthrough happens in a vitreous hemorrhage. Simple doing a vitrectomy is not the modality of treatment. You have to chase the disease till the lesion subside with the help of various anti-VEGFs, whatever the patient. Preferably a choice molecule would be aflibercept or a brolucizumab. But if the patients can't afford, you can go ahead with any other anti-VEGFs. Thank you.
Thank you, Dr. Thank you, Dr. Prashant, for that excellent talk. I know that you have to go to another hall for another presentation, so I'll try to ask you a quick question. What do you think is the role of TPA in these cases? Now, when you go inside and then you see these massive subretinal hemorrhages. Now, when would you decide to inject a TPA?
Yeah, if it is encroaching into the fovea, first thing, and second, the height of the lesions are too high, where I feel if it is less than 200, 300 microns subretinal hemorrhage, I believe the natural course has almost a similar course like putting a TP and this. Second thing is, when you do a vitrectomy in majority of the cases which do not have much of a height of a subretinal hemorrhage, and then you position it, it usually disappears. So that is the way. Plus you are treating the lesion per se with the help of a anti-VEGF molecule.
So when you say position, you mean to say you don't inject TPA but put in gas?
Yeah, simple air. I don't put a gas as well. Unless it's a too big amount, I somehow...
Because in the case in which you had not put in TPA and you said you had not put in TPA, that case, many of us may have put in TPA and put in gas and an anti-VEGF, all the things together.
Exactly.
So.
The height of the hemorrhage was not that dense or thick inside the retinal layers, and it was such a minimal thing, and it was such a massive, and what experience says is that it is not necessary that you have to put a TPA. Unless I see a big height, it's 0.5 millimeter or something like that, I would not go for a TPA. And you can see the natural course of it, resolution which I have followed it up with.
Thank you, sir. So we'll get on with the next talk. Is Rahul ready? Now, the one, I think some learning lessons from the cases Dr. Prashant showed. If you remember the first case, this innocuous looking PED and then later it bleed. Looking at other eye often gives us a clue. I mean, you'll need to look at other eye, you may be able to pick up pachychoroid in that patient, and probably, you'll be thinking more in terms of PCV. So you'll be looking out for, an increased manifestation in that case, even though initial ICG, did not pick up any polyps. In the second case, he talked about, a PED which kind of ripped. So again, we have some data from literature. The PED size actually gives us an idea about if you have a PED, the base diameter around 800 microns or more, or the height of the PED more than 400 microns. It's known that these eyes have a high risk of rip. So you probably need to expect a rip in these patients. So that you need to keep them in the loop. And as he rightly said, maybe this concept of sub-RPE fluid now, we have better drying agents, especially with respect to the sub-RPE fluid. So probably brolucizumab may work in these patients. Yeah. So we'll move on to the next talk. Dr. Rahul will be talking to us about the drusen. So we see a lot of sometimes when we see patients, we see different kinds of drusens. Now, do they all represent the same understanding? Are there some with higher risk of CNVMs? Do you need some? There are some instances where you just need to follow them up, or you don't need to follow them up. So Dr. Rahul will probably give us an outline.
Thank you, sir. So good morning, everyone. I'll be talking to you about drusen's and what is the story behind it. So first of all, what are drusen's? They are focal yellow or white deposits of extracellular debris located between the RP and Bruch's membrane. So they occur naturally with age. They are asymptomatic unless it is in a subfoveal location. They are the hallmark of age-related macular degeneration and one of the most common early signs of non-exudative ARMD. So they have been classified on different aspects. On the basis of appearance, they have been classified as hard drusen's, soft drusen's, cuticular drusen's. So hard drusen's are smaller and they have distinct margins. Soft drusen's are larger, they have mound-like appearance, and usually the margins are not very clearly delineated. And cuticular drusen's appear spheroidal or triangular on OCT. On the basis of size, they have been classified as small, intermediate, and large. So another distinct clinical entity is SDD or subretinal drusenoid deposits. So it is not just like a drusen. They are located above the RP, whereas the drusens are below the RP. They're also called as reticular pseudodrusen. So what is the natural history of drusen? So what we have found out is that the average drusen volume is found to increase over time. And they have a dynamic undulating growth pattern. So bigger drusen volumes, they usually have a tendency to spontaneously regress with the possibility of progressing to geographic atrophy or neovascularization. So drusens have been analyzed both quantitatively and qualitatively. So on quantitative analysis, the baseline drusen volume, it gives a good prediction, gives a good predictor of the development of late AMD changes. So drusen volumes of more than 0.03 square millimeter on OCT has been associated with a 4-fold increase of developing late AMD changes. Now in this study by Abdel Fattah, what they found was like one eye was the inclusion criteria was the patients who had wet AMD in one eye and dry ARMD in the other eye. And what they found was like patients who had this larger drusens, by the end of 2 years, about 10% of the patients, 10 to 15% of the patients required develop into geographic atrophy and wet AMD, and the other around 20% of the patients develop into geographic atrophy at the end of 2 years. On qualitative analysis of drusens, it's basically on the reflectivity of the content of the drusens. So we have drusens with low inner reflectivity, drusens with moderate inner reflectivity, and drusens with high reflectivity. So sometimes we see drusens with some focal hyperreflectivity over the area, drusenoid region. So this lesions and the drusens with hyper or hyporeflectivity, they have a high tendency to develop into RP atrophy. Now, the cellular basis also for the focal hyperreflectivity over the drusens is still not unknown, but it may usually represent the infiltration of inflammatory cells, which finally leads to disruption of the RP layer. Now, another entity that we have is sometimes we see that the inner structure of the drusen is not very uniform. So we have something called as ODS, that is OCT reflective drusen substructures. So what this study did was it classified into 5 types. So we have the drusens with, called as L type, whereas there's a low reflective course. You have the H type where you have high reflective course. You have the C type which have conical debris. The S type where it is a split reflective drusen, that is you have high reflectivity and low reflectivity, and we have the drusens with no debris. So in this classification, what they found was the L type, H type, C type, and the S type, they have a high tendency to go into geographic atrophy. And among them, the one with the conical debris have the most rapid progression. Now, Spade and group, what they did was they studied the adaptive optic imaging of subdrusenoid SDTs, that is the retinal pseudodrusen. Now, like I told, it's not the conventional drusen. The SDTs usually have like Dr. Parveen ma'am had already mentioned, they have a much more, they affect the retinal function much more seriously. So what they found was in the adaptive optic imaging, there was a reduced visibility of cones overlying the pseudodrusens. So the possibility could be, what they postulated was, it could be because of a change in photoreceptor orientation, or probably an alteration of the cellular architecture, or maybe probably even the density of cones might be reduced. So the cone density is usually relatively well preserved over conventional drusen in the AO images. And the IDV pseudodrusens have a decreased retinal function in ARMD, independent whether the patient has a neovascularization or a RP atrophy. So what happens is in the conventional drusen, the RP is displaced by the sub-RP material. So mechanically, there's no disruption to the cones. Whereas in pseudodrusen, since the drusenate material is above the RP, it physically juts into the subretinal place and is in very close contact with the photoreceptors. And probably that is the reason why it causes more visual damage. Another entity is refractal drusens. So we have seen a lot of times calcified drusens actually. So it has been studied histopathologically by Bristler and group and Curico and group and all. So what they found was it is not a complete calcification of the drusen. They did find few calcified droplets in the drusen, but it's not completely calcified. So they termed it as refractal drusens. So they have been defined as drusenate material containing small refractive spherules. Clinically, you can see them as white glistening dots within the drusen. And on OCT, you can see the small hyperreflective dots, which are basically spherules of calcium phosphate. Now, in this OCT, the upper image, the left side is you have the color fundus image, and the right you have the autofluorescence. So you can see the refractal drusens on the left side. And initially, they had, you can see a high ring of hyperreflectivity, hyper signal in the autofluorescence. And over a period of time, the refractal drusen becomes more contracted, and it leads to a hypo signal in the AF signals, in the autofluorescence. This is over a period of 30 months. But if you actually look into it, the size of the atrophy, that is this area of hypo signal, is actually larger than the actual drusen. So what happens is the loss of RP starts over the refractal drusen and is usually confluent. Now, usually in such cases, what I feel is autofluorescence imaging is more sensitive indicator than color fundus picture. So to take home message, individual risk of progression to advanced AMD within a given time still remains challenging. We cannot predict how fast they will do, but we do know certain factors that few clinical OCT imaging features, we need to keep them on a close watch. So it has an important role in predicting the AMD disease progression. Thank you.
Thank you, Rahul. I think that was a wonderful presentation. May I invite Dr. Manoj to give his talk on current nomenclature in AMD. So while his slides are being put on, if you have to see at Chaitanya, you have all the diagnostic modalities. You're doing cutting-edge technology. But for the public as such, how do you would want people to follow the drusens? By autofluorescence, by colored photography, and how frequently?
Color photography definitely is only for, I feel it's more of a documentation process, but we do have multicolor imaging, which gives much more information. The Heidelberg Spectralis one, and also OCT and autofluorescence definitely gives a much more. So as Dr. Parveen ma'am had said, you cannot rely on just one imaging modality. We are spoiled with so many choices, so definitely we have to depend on all of them, most of them, and it does, because finally CNVM, because the delay in diagnosis actually leads to very bad vision prognosis. So that is why they need to be kept on a close watch with multiple imaging.
Thank you, Dr. Rajay. First of all, I'd like to formally welcome you for this session. Dr. Rajay Arora is a very senior vitreoretinal surgeon, and he's got a lot of innovative things to speak every time he comes to a conference. He's got around 40 years of experience, and we are proud to have you with us here today, sir.
Not 40, you make me seem so old, yeah.
Okay. So I'll get on with my talk on newer terminology in AMD. So my focus will be on neovascular AMD. Dr. Parveen madam has made my life simple. She has almost introduced you to most of the terms that I would want to talk to you about. So basically, I have taken many of these terms from the consensus nomenclature for reporting neovascular AMD that is published in ophthalmology. 2020. So the term choroidal neovascularization, nowadays we are very familiar with this term. Nowadays the term that is, the standardized term that is supposed to be used is macular neovascularization. This is exactly because, as Madam said, all the neovascularizations, they do not start in the choroid. Many of them can also start in the retina, like the retinal angiomatous proliferance. So they start intraretinally. So therefore, the term macular neovascularization is a better term. So type 1 macular neovascularization is when you see the neovascularization under the retinal pigment epithelium. And type 2 is like when you see it above the retinal pigment epithelium. And this is where now you see the classic fluorescence on FFA. And then you can also have a mixed type 1, type 2 MNV, where you have neovascular elements under the retinal pigment epithelium and also over the retinal pigment epithelium. So this is in simple type 1 and type 2. And you also have type 3. Madam had showed us some wonderful photographs. The hallmark may be a hot spot on ICG. And typically, these patients have a large PED and you have intraretinal reflectivity, and often they have a lot of intraretinal fluid. So this is how you to differentiate from other types of CNVMs. And sometimes, you can also see a sub-RPE lesion. So the type 1 activity in a patient with type 3 CNVM, which is not at the same site. So this the consensus group has defined this as type 3/1 MNV. And we also now know that OCTA is a very useful investigation, these tests, because these help us to understand that these type 3 neovascularization starts off in the retina, especially if you look at the deep capillary plexus, you would see them very evidently. And also nowadays, we like to characterize or differentiate membranes on the basis of OCTA. OCT angiography is now an essential part of management of choroidal neovascularization. So different patterns have been described. We have the Medusa head pattern, the C-fan pattern, and indistinct pattern. So these patterns now are differentiated on the basis of their central trunk and their branching and anastomosis. So based on this, we have these descriptions, and they all mean that it's an active CNVM. But when you see on the OCT angiography a pattern where you see the main trunks with not much of branching, then we call it a prune tree pattern, and this often denotes an inactive CNVM. So these are some terms that you will come across when you read the papers. Then the next term is double layer sign. It's not a new term, but then we need to know this. This is when the retinal pigment epithelium is separated from the underlying brooks. Normally, you see them as one layer, but when you see there is a separation, we call this double layer sign, specifically in the setting of polypoidal choroidal vasculopathy, where you see all this pachychoroid, the large dilated hala vessels underneath. If you take ICG angiogram in this patient, you will see a branching vascular network which corresponds to the double layer sign. There's also another term called SIRE, which is shallow irregular retinal pigment epithelial elevation. Now this is a term which is very similar to DLS, but this term is used in the setting of non-PCVIs. So when you have a typical neovascular AMD, then you use this term SIRE. They have also given a definition for this. The height of the SIRE should be within 100 microns, and the lateral extent can be more than 100 to 400 microns. These eyes, if you take an OCT angiography, you may see the presence of a non-exudative CNVM. I'll come to that. You can have a similar appearance even in a CSR, when you call it as FIPED, flat irregular pigment epithelial detachment. So this is the same term for same description in different entities. So non-exudative CNVMs, Parveen Madam had dwelled on this. So this basically, when you do OCT angiography, we pick up these membranes. But if you do a fluorescent angiography, sometimes you don't see anything. And sometimes on the ICG, you may see a plaque or on a late fluorescence. So these patients also, on the OCT, don't have any intraretinal fluid. So these are patients whom we call as non-exudative CNVMs. This primarily, it's not that now after treatment you see this, you call it non-exudative. This is primarily when you see a patient, like when a patient with dry AMD, when you take an OCTA and you see this pattern, you call it non-exudative CNVM. What is the importance? 3 to 28% of them can actually convert to an exudative AMD over a period of 1 year. Sometimes overlying the retinal pigment epithelium, you see this hyperreflectivity, and this is what we commonly call as SHRM, subretinal hyperreflective material. You could think of these materials either vascular or avascular. Vascular in the sense they may denote a CNVM as such, like a type 2 MNV. which lies above the retinal pigment epithelium. Or no, it may not be a CNV, but it may be a type 1 MNV like in this patient with some manifestation like subretinal fluid or subretinal fibrin or subretinal hemorrhage or even exudation, which may which may be the cause of this hyperreflectivity. Now, what is the importance? At baseline or when you see a persistent SHRM or you see a reappearing SHRM, these are all poor prognostic signs, whereas if you see a regressing SHRM, it's a good prognostic sign. One needs to differentiate this from acquired vitiliform lesions, which is also seen above the retinal pigment epithelium in the setting of neovascular AMD or even the setting of drosenoid PEDs, which is nothing but white, lipofuscin deposits. So if you take a fundus autofluorescence in these patients, now you will see this material fluorescing as against the rest of the SHRM which may not fluoresce. So sometimes now under the retinal pigment epithelium, you can see these linear bodies, hyperreflective linear bodies, which are called as sub-RP lamellar hyperreflective deposits. Now this looks like onion peel, so this is called as the onion peel sign. These deposits start off at the retinal pigment epithelium underneath, and they start going down to the base of the PED. So these are typically type 1 choroidal neovascular membranes, which has been chronically treated with anti-VEGF therapy. Now, if you take an infrared photograph of these patients, now you will see these lesions, all these onion peel deposits as hyperreflective. And this has to be differentiated from another condition which is called hyperreflective crystalline deposits, which is a term used for dry AMD patients. In dry AMD patients also you can have these calcific deposits under the drusens. Multilayered PED is a term that is that is referred to a type 1 pigment epithelial detachment, which has got some contents, and the contents being here, you see these lamellae, which are seen in the middle of the PED. It almost fills up the whole of the pigment epithelial detachment. The neovascularization lies between this lamellae and the retinal pigment epithelium, and many of these also have an underlying prechoroidal cleft. The importance is these are again type 1 MNV eyes, which are on chronic anti-VEGF therapy, and many of these eyes have very good visual acuity. And the term pachychoroid neovasculopathy is in the setting of pachychoroid. When you see these large, dilated vessels, halar layers, vessels with overlying chorioacupillary compression, and then you also see a type 1 macular neovascularization. In this patient, you can also see an SHRM. This is an example of a neovasculopathy. These patients have scanty SRF, hemorrhage, or intraretinal fluid, and they respond well to anti-VEGF therapy. This also, madam did speak about the term aneurysmal type 1 neovascularization is now the term that is used for polypoidal choroidal vasculopathy, because investigators believe that the polyp is not a right term to describe these patients. They are actually aneurysms. Also, we have these descriptions. When you read literature, you'll see the description, the thumb-shaped PEDs, sub-RP ring-like lesions, complex PED. So these are terms that are commonly used now to describe OCT findings in PCV, which again comes from the consensus Asia-Pacific PCV work group. Late geographic hyperfluorescence is a term that is described in ICG frames. So if you take late frames ICG, you may see these hyperfluorescent patches. All of these may not really may not reflect the neovascular elements that you see in the earlier phases of angiogram. So this is referred to as late geographic hyperfluorescence. The importance of this is this is a characteristic finding on PCV patients. So if you see that in a patient, you could think that you are dealing with the PCV patients, because it's very uncommon in exudative neovascular AMD. With regard to fluid, we are all aware of intraretinal fluid and subretinal fluid. But now the term that is that we are speaking about a lot is the sub-RPE fluid. There's nothing but the fluid inside the PED. And we nowadays we look at the anti-VEGF response to this fluid. Any drug which is effective in in drying this would be considered as a good drying agent, like brolucizumab. Also, we have this hyporeflectivity between the CNVM network and the sclera. This is referred to the prechoroidal cleft. We saw this earlier as a defining feature of multi-layered PED. There are two types of clefts. When you put a patient on anti-VEGF therapy, and if a cleft appears, if the cleft appears within 6 months of therapy, they are called early clefts. These patients have poor prognosis as against old clefts which happen beyond 6 years, beyond 6 months. And the term degenerative cystoid spaces, again, this is covered. This refers to presence of these intraretinal fluid which do not go away with anti-VEGF therapy in the setting of a scarred CNVM. So you have an SHRM here, which is non-vascular, and then you have this intraretinal fluid. And also here now you see an outer retinal tubule. That all tells you that this is a dying down process. And these patients do not do well with anti-VEGF therapy. Outer retinal tubules now have to be differentiated from intraretinal fluid. They have a hyperreflective border, as you can see here, as against intraretinal fluid, which does not have that. You can see that in both dry AMD as well as in scarred CNVMs. The term, when you clinically see a patient now with atrophy around a CNVM, the term that has to be used is macular atrophy associated with CNVMs.